outline the effect of vitamin D. Dr. Marco Infante from Tor Vergata, Rome. Marco, please.
Thank you, Dr. Ricordi, and the organizer for the invitation to this symposium. So I'm going to talk about the role of vitamin D in type 1 diabetes. First and foremost, vitamin D is a steroid hormone that can be obtained from diet, but it is mainly produced in the skin from its precursor, that is 7-dehydrocholesterol. Under solar UVB radiation, 7-dehydrocholesterol is converted into its vitamin D3 form. Thereafter, vitamin D3 is then transported to the liver, where the 25-hydroxylase converts it into the major metabolite of vitamin D that indicates the status of vitamin D, and is called 25-hydroxy vitamin D3, or calcidiol. So calcidiol is then transported to the kidney, where the rate-limiting enzyme of vitamin D metabolism, 1-alpha-hydroxylase, converts it into the active form of vitamin D, that is called calcitriol, or 1.25-dehydroxy vitamin D3. So it has become clear over the last decades that vitamin D effects go well beyond the regulation of bone homeostasis and calcium metabolism. In fact, one of the first evidence of this is that vitamin D receptor, the receptor vitamin D active form, is expressed in almost all human cells, and it plays a central role in the biological actions of vitamin D, regulating the expression of several genes involved not only in calcium phosphate homeostasis, but also in cellular and proliferation and differentiation and immune response in a ligand-dependent manner. So calcitriol binds to the vitamin D receptor, and vitamin D receptor is a nuclear receptor that acts as a transcription factor. It binds then to a retinoid ACE receptor, forming an heterodimer, and this heterodimer then binds to vitamin D responsive elements into DNA, stimulating the transcription of several genes. And as I mentioned early on, vitamin D receptor is expressed in almost all human cells, including pancreatic beta cells and immune cells, especially antigen-presenting cells, macrophage, dendritic cells, and T lymphocytes. Moreover, the rate-limiting enzyme of vitamin D metabolism, 1-alpha-hydroxylase, is expressed in antigen-presenting cells, in both murine and human antigen-presenting cells. And so these cells are therefore able to synthesize calcitriol under specific immune stimuli, such as interferon gamma. Calcitriol can so exert several immunomodulatory and anti-inflammatory effects, mainly downregulating the adaptive immune response, inhibiting the antigen-presenting ability of dendritic cells and macrophages, stimulating macrophage differentiation and activation, promoting their antimicrobial activity, but it also promotes a shift of macrophage polarization from a pro-inflammatory phenotype toward an anti-inflammatory phenotype, and it promotes the shift of T cell phenotype from a effector phenotype towards a regulatory phenotype, upregulating the expansion and the proliferation of T regulatory cells and T helper 2 cells, thus inhibiting T helper 1 and T helper 17 cells that are known to be pro-inflammatory. So several studies have investigated the safety and the efficacy of vitamin D in several autoimmune diseases, such as rheumatoid arthritis, Crohn's disease, systemic lupus erythematosus, and also type 1 diabetes, finding positive results but also controversial results. So one of the first evidence of the involvement of vitamin D deficiency in autoimmunity and autoimmune disease come not only from the fact that the vitamin D deficiency is more frequent in autoimmune diseases, but also that the incidence rates of some autoimmune diseases like type 1 diabetes is higher in a region at higher latitudes. And this happened because I mentioned Dr. Ricordi early on that in regions that are at higher latitudes, they are more distant from the equator, where the zenith angle is greater, and so the UVB irradiance is lower and the vitamin D3 production is even lower. And this is a study showing that how there was a gradual rise in the incidence rates of type 1 diabetes in Finland. That is actually the region and the country with the highest prevalence of type 1 diabetes in the world. And it's interesting to note how this gradual increase in the incidence rates was paralleled by the progressive reduction in recommended vitamin D intake throughout this period, going from 1965 through 2005 in this country. So several observational studies have demonstrated that patients with both new onset and established type 1 diabetes have a lower level of vitamin D and an higher prevalence and more profound vitamin D deficiency. And this is a recent Italian study demonstrating not only that the patient at the clinical onset of type 1 diabetes have higher prevalence of vitamin D deficiency and lower levels of vitamin D, but also that vitamin D deficiency is more prevalent in enterovirus positive versus enterovirus negative patient. We know that enterovirus is a well-established environmental infection triggering factor for type 1 development in patients with high genetic risk for this disease, and maybe this study may suggest that patients with vitamin D deficiency are more prone to the infection and therefore to the development of type 1 if they are at increased genetic risk of type 1. So although the cause-effect relationship between vitamin D deficiency and type 1 diabetes has yet to be demonstrated, several studies try to investigate the effects of vitamin D supplementation in determining the risk of type 1 diabetes in different stages of life. And these are studies demonstrating that the maternal intake during pregnancy of cod liver oil, but that is rich in vitamin D and also omega-3, but also other food sources of vitamin D, is able to reduce significantly the risk of islet autoimmunity and type 1 diabetes in offspring. However, other studies demonstrated that there is no significant association between maternal intake of vitamin D during pregnancy and the risk of advanced beta cell autoimmunity and type 1 diabetes development. And this was also confirmed by this meta-analysis of observational studies demonstrating that there is no association with the risk of diabetes. However, if you look at the studies regarding the intake during the during the early childhood and the first stages of life, data are different, because this, for example, is a birth core finish study demonstrating that individuals and subjects taking vitamin D supplementation during the first year of life at the dose of 2,000 international units per day have a significant lower risk of type 1 diabetes compared to those that were taking less than 2,000. And this was confirmed again by the meta-analysis that I showed early on, that demonstrate that instead that the vitamin D intake during early life may be associated with a significant risk reduction in development of type 1. Another important point is the timing of supplementation. This is a study showing that use of cod liver oil during the first year of life, showing that children supplemented with cod liver oil between 7 and 12 months of age have a significant lower risk to develop type 1 compared to those that were supplemented before 6 months of age. A possible explanation could be that the adaptive system in humans becomes competent only after that period, after the first six months of age. And maybe the vitamin D could have no immunoregulatory effect in that period, but it's just speculation. So another important point is also the role, to study the role of single nucleotide polymorphism of several genes involved in vitamin D metabolism. And this study actually showed how higher levels of vitamin D at birth are associated with lower risk of type 1, but in children carrying a specific polymorphism of vitamin D receptor. Also, this study showed that higher levels of vitamin D binding protein in mothers at delivery is associated with a reduced risk. So, in regard to the vitamin D binding protein, this genome-wide association study described as that vitamin D binding protein could be a potential novel autoantigen in type 1 diabetes. The authors in fact found that T-cell reactivity against vitamin D binding protein is actually higher compared to controls in non-obese diabetic mice. That is an animal model of type 1 diabetes, but they also showed how the patient with type 1 diabetes exhibit higher level of serum anti-vitamin D binding protein antibodies that are actually inversely correlated with the serum levels of vitamin D during winter time. And the immunohistochemical localization analysis revealed that this protein is expressed within the glucagon-positive islet cells. So this study was already showed by Dr. Rigori, but just to underline that also in adults there are different data, because if you look at this slide, individuals in the lowest quintile of vitamin D concentration, below 40 nanogram per milliliter, have the 3.5 lower risk of developing type 1 diabetes compared to the individuals that are in the highest quintile above 40 nanogram per milliliter. And this result were confirmed by another study in adults where the serum levels of vitamin D above 40 nanogram per milliliter were associated with the lowest risk of developing type 1 diabetes, maybe suggesting that the protective level against the development of type 1 are well above the threshold recommended for bone health by the Endocrine Society guidelines. So several preclinical studies demonstrated that cholecalciferol and calcitriol supplementation in non-obese diabetic mice can prevent the diabetes and insulitis when administered at an early age, but they are still able to arrest disease progression when administered at an older age. And the proof of concept of an effect of vitamin D on the human immune system comes from this study. This is a randomized controlled trial showing how the 1-year supplementation of cholecalciferol in young patients with new onset of type 1 diabetes is able to improve the suppressor function of T regulatory cells, so suggesting the vitamin D as a potential adjuvant immunomodulatory therapy in type 1 diabetes. However, if you look at the randomized controlled trials, the results are controversial in terms of changes in hemoglobin A1C, insulin dose requirements, fasting and stimulated C-peptide. But this heterogeneity could be explained by the heterogeneity of study duration that ranged between 3 months up to 24 months, and also by the difference in administered vitamin D formulation and the administered vitamin D doses. And so we are currently conducting a phase 1-2 pilot trial to assess if vitamin D in association with other anti-inflammatory agents like omega-3 fatty acid is able to arrest and halt autoimmunity progression and prevent residual beta cell mass and function. But an important concept that was probably missed by the most of the previous studies, that the administered dose of vitamin D will depend on the serum levels of 25-hydroxy vitamin D at baseline, and will be then progressively adjusted according to the serum levels reached during the follow-up by the participants in the study. So the concept of the target, because most of randomized controlled trial aiming at investigating the role of vitamin D in several clinical settings, including autoimmune disease, failed probably because of the inappropriate study design. And particularly, health outcomes should be evaluated and assessed in relation to serum levels reached during the follow-up, rather than only in relation to vitamin D administered doses alone. And this is the case of the VITAL study that has been recently published in New England Journal of Medicine, a study that found negative results in terms of vitamin D supplementation and prevention of cancer and cardiovascular disease. But if you look at the study, VITAL study has several limitations. The main limitation is the lack of assessment of vitamin D status during the follow-up, the lack of information about sun exposure and outdoor physical activity of participants, the misleading definition of 2,000 international units per day as an high dose of vitamin D, and no increase in vitamin D doses according to BMI. In fact, 2,000 international units per day may be too low dose for overweight, obese individuals, as it has also been stated by Endocrine Society guidelines on treatment and prevention of vitamin D deficiency. So in conclusion, we can say that vitamin D exerts several immunomodulatory and anti-inflammatory effects, that vitamin D deficiency that is highly prevalent in type 1 diabetes should be promptly diagnosed and treated in subjects with increased risk, genetic risk of type 1 diabetes, especially during the early childhood. And several studies demonstrated that the efficacy of vitamin D in mitigating or even reversing autoimmune responses in non-obese diabetic mice, although clinical studies show conflicting results. So a large-scale randomized controlled trial are needed in order to better investigate the efficacy of vitamin D supplementation in autoimmune diseases, but also in type 1 diabetes. But it's important that this randomized controlled trial will be properly conducted with the assessment of clinical outcome that should be primarily based on serum vitamin D concentration rather than solely in relation to vitamin D doses. And then the final important point is also to study in prospective studies the role of single nucleotide polymorphism in genes involving vitamin D metabolism, such as genes encoding the vitamin D binding protein, vitamin D receptor, and also the vitamin D hydroxylase involved in its synthesis pathway, to understand if there are some polymorphisms in individuals requiring higher dose of vitamin D to reach the proper target in order to achieve the immunomodulatory effect of vitamin D. Thank you for your attention.
Yeah, is there any question?
Yeah, there are several compounds, but actually, okay, can you?
You have to repeat.
Okay. You are asking about the difference in the efficacy of different compounds and formulation of vitamin D, right? Okay. Yeah, there are several compounds, but it has been shown from the literature that some compounds, there is no clear data about the superiority of a specific and given compound versus another, at least in autoimmune disease. The data are very controversial in this. But
he was asking between vitamin D and other vitamins, like vitamin C, vitamin K,
okay.
Vitamin K.
Okay. Now, to date, the data on the mechanistic data about immunoregulatory function comes mainly from vitamin D. There are some data about the synergistic effect of vitamin D, for example, with vitamin K, but this regards other clinical conditions, for example, cardiovascular disease, not autoimmune disease.